So, hi everybody, welcome to our very first mental health podcast. This is episode 1 of series 1. And so our aim for these series is to provide you information about patient experience of mental health diagnosis and treatment. And to improve that, we're doing that by sharing information about different areas of mental health. And it is aimed at you guys in primary care, so all clinicians in primary care. This is the first of a series, and we will be exploring lots of topics with local experts, and the 4 topics are bipolar, nutrition, metabolic system and cardiovascular health, and that's associated with antipsychotics, common prescribing and deprescribing for serious mental illness. And then we've got a personality disorder, complex PTSD, emotional sensitivity, and that'll be done in 2 parts. So in each episode, we aim to have an overview of the diagnostics, an outline of the treatment plans, and then an open discussion on the practical treatments for patients. So now that I've got your attention and you know what the series for you, I'm going to introduce myself and our main guest today. So I am Mel Hall, and I am the head of primary care mental health services in Sheffield. And I've been working in mental health now for over 26 years, from support worker to my current role as head of service. And I've got a background in commissioning, operations and national policy. But really, I'm just a mental health social worker. So our expert today is Dr. Pranav. And Pranav, over to you.
Hi, yes, thank you. So I'm Pranav. I am a consultant psychiatrist working with the PCMHT in Sheffield.
Fabulous. Thank you, Pranav. So I'm going to ask you today about bipolar disorder. So without further ado, Pranav, what is bipolar disorder?
Yeah, what a big question. So bipolar affective disorder is essentially an episodic mood disorder with discrete manic or hypomanic episodes and discrete depressive episodes. So when we talk about manic or hypomanic episodes, the sorts of symptoms that we're talking about there are things like elevated mood that aren't in keeping with circumstances, increased energy and a decreased need for sleep, restlessness that can border on to agitation or irritability, pressure of speech, so that's when somebody's speaking extremely quickly and they're uninterruptible, overconfidence that can sometimes tip into grandiosity, which is when people truly believe that they are something special. And then reckless or out of character behaviors. So this can include things like increased spending, increased substance misuse or alcohol intake, sexual promiscuity, anything that is not in keeping with that person's normal behavior. In order to sort of differentiate between mania and hypomania, it's about understanding how these symptoms then impact on that person's functioning. So generally speaking, if somebody is manic, they're not going to be able to function well at all. They won't be able to look after themselves, their dependents, go to work, things like that. Whereas someone who is hypomanic, their symptoms may be less severe, and so they may well superficially appear like they are functioning. However, when you dig a bit deeper, you realize that they're not functioning that well. Mania has to last at least 7 days in a row, and hypomania at least 4 days in a row. And then with those depressive episodes, they present exactly the same way as unipolar depression and would need to last at least 14 days in a row to constitute a depressive episode.
Crikey. So do you think people would have insight then when they get to that state of hypomania or mania?
Yeah, it's a good question. I think people can have insight into those episodes. Certainly in the early stages, what we find is that when we work with people with bipolar to recognize some of those early warning signs. So a couple of nights of poor sleep, for example, or an increase in impulsive spending. It's very unique for each person, but people can start to learn some of those signs and those triggers and gain insight. But yes, I think for some people, at the most extreme points of their illness, they can lose insight.
Gosh. So how common is bipolar disorder?
So it's more common than you'd think. So the lifetime prevalence of bipolar affective disorder in the UK is around 1 to 2% of adults. So what that means is 1 to 2% of adults will develop bipolar affective disorder at some point in their lifetime. So that's relatively common. That prevalence increases if there is a family history of bipolar. So if somebody has a first-degree relative, so that's a parent or a sibling, that increases that prevalence by tenfold.
Yeah, definitely. I remember working with somebody who bipolar was within the family. And things that we did, like you talked about there with the insight, was when she gained insight. So when she sort of rebalanced, we went through an advanced statement. And so things like asking, what would you prefer? I remember she didn't want to go back onto olanzapine because olanzapine made her put quite a lot of weight on. So she really, but when she was really unwell, she knew she had to take it. But her advanced statement almost said, look, please don't do it as your first line, but if I have to take it, I will. But don't give me any cake. People, when they came into hospital, would keep giving her cake. So yeah, it was really quite frustrating when she'd come out of hospital. She'd then have a load of weight to lose, which when you've been high, sometimes you become low in mood, and being overweight was one of those triggers for her. But there you go. That's the social worker in me. Okay. So are there particular groups of symptoms which might be misinterpreted as bipolar?
Yeah, I mean, I think as you can appreciate from the symptoms that I've just described, there can be an overlap in symptomology. Any sort of mental health condition that can cause emotional dysregulation. So emotional dysregulation is a extreme fluctuation in mood. Can be mistaken for bipolar affective disorder. So things like emotionally unstable personality disorder, post-traumatic stress disorder, or ADHD can all commonly cause emotional dysregulation. Things like
it's a good job we're going to be looking at that in one of the next series, then, isn't it?
Absolutely. Things like acute intoxication, but also chronic substance misuse or caffeine misuse, we're seeing quite a bit of as well. Can mimic bipolar type symptoms. And then also physical health causes, things like thyrotoxicosis or side effects from steroids or acne medications, delirium. These can also mimic those symptoms.
Right, so I guess it's really important then to be checking all the physical health symptoms, because I guess with some of those diagnoses, medication's really effective if you're treating it with the right stuff.
Absolutely, yeah.
So talking about medications, sodium valproate, that's used sometimes. How's that used? When's it used? Because I understand it can be quite toxic.
Yeah, sodium valproate is a very effective mood stabilizer in bipolar affective disorder. It's also used in epilepsy. However, it can have very serious teratogenic effects, so effects on an unborn child. And as such, Sheffield Health Partnership University Trust, they have to register all females of childbearing age who are prescribed sodium valproate. And they have to go through a series of checks annually if they are prescribed sodium valproate. In reality, it's very, very rare now to newly prescribe somebody under the age of 55 on sodium valproate, and it would be reserved for very exceptional circumstances.
And so the sort of numbers, I think if I remember, the numbers we were looking for Sheffield was something like 15. They were
Yeah.
incredibly low numbers. And so when people have those reviews, what sort of thing are we looking at for those reviews?
So in those reviews, obviously we are checking their mental health and their relative stability. But we're also looking at whether they have any plans to get pregnant, whether they are on a long-term contraception, and whether they fully understand the risks that are associated with taking sodium valproate. And so we give them a lot of paperwork to go through, and we will sign it together and send it back to the trust, just to document and to ensure that they are fully informed of what they're taking and why.
Okay, thank you. And I think part of that reason is because people, am I correct in knowing that women that postpartum are at higher risk of depression, but also infanticide? Is that right?
So that's a separate topic. So with regard to sodium valproate, the biggest risk is on the unborn child.
Yeah.
And the exposure to sodium valproate, especially early on in pregnancy. So often women won't be aware that they're pregnant before the damage is already done. But in terms of bipolar affective disorder and the sort of perinatal and postnatal period, that is a very important thing that people need to be aware of. So during pregnancy and in the postnatal period, there is a higher risk for relapse, and that can present as both postnatal depression or as mania or hypomania, and that can obviously have a huge impact on a person's well-being, but also the well-being of the child and the wider family. So that's why we would recommend that people always seek advice, from perinatal services as soon as possible when someone becomes pregnant. But ideally, seek that advice prior to becoming pregnant, because I know that perinatal services do offer preconception advice.
And so, talking of things that I think I know, some term that I've heard a couple of times is about different types of bipolar, sort of rapid cycle. Is there a slow cycle? What's that?
Okay, so this is this is quite a wide-ranging question, because it kind of depends on what you're Googling. But essentially, in the UK, we use something called the ICD-10, which is the International Classification of Diseases, version 10, to classify illnesses, including mental health conditions. And in ICD-10, bipolar affective disorder is classified with regards to the symptoms at the time of that presentation. So, for example, you might see a diagnosis and it says bipolar affective disorder, current episode, mania. So it's essentially the Ronseal of classifications. Now, what happens is, obviously, patients will look up their bipolar affective disorder and they'll see reference made to various different types. So often what we get asked is, do I have type 1 or type 2 bipolar? Now, type 1 and type 2 bipolar are used in a different classification system, which is the DSM classification system. And that's used predominantly in the United States and in Canada, which is why it's so widespread. Interestingly, ICD-11 are also going to use these classifications, but these haven't been implemented in the UK. And that's why we don't use them in our diagnoses. However, reference will still be made to them because patients are interested.
Okay.
Yeah, and then in terms of rapid cycling, I think sometimes people think that rapid cycling means you have very short manic or depressive episodes. But actually what rapid cycling is it's 4 or more abnormal mood states in a year. So 4 episodes of mania, hypomania, or depression per year. But all the other criteria remain the same in terms of the duration and the symptoms themselves.
So those patients that sometimes say, well, this week I was really happy and last week I wasn't. No, that's not bipolar, right?
That absolutely, yeah.
So that's more likely to have more like the unstable, emotionally unstable personality disorder, or that very complex PTSD. Okay. So what could a GP do if they think that that the patient has got possible bipolar?
Yeah, so I think if a GP is concerned that somebody has bipolar, definitely refer on to mental health services. But it would also be useful when making those referrals if you could include the duration of those episodes, so the manic and the depressive episodes, as well as the symptoms, any sort of substance misuse history, and if any organic causes have been ruled out. So, for example, have they had a thyroid function test done? Has there been a review of physical health medications? And especially in older age groups, it's more likely that if somebody is presenting in an older age group with manic type symptoms for the first time, it's more likely to be an organic cause than a mental health cause.
When you say older, what kind of age is
Yeah.
older, Pranav?
So when we look at bipolar, the reality is bipolar can present at any time in adulthood, but the
Right.
average age of onset is around 20 to 25 years old.
Uh-huh.
And so we see a peak um, in the late teens to 20s and another peak in the 40s.
Oh.
So if we see people who are presenting, like I say, for the first time with significant mood changes and they're aged sort of 60 or above, I'd be
Mm.
more concerned about there being an organic problem than it being a new presentation of bipolar affective disorder.
Okay, that makes sense. And I guess we can adapt these things, like giving people diaries and just using a happy face or a sad face. If people don't, if English isn't their first language, or if there's some communication challenges, just knowing that they've been trying it for the last 6 months and what their mood is really like, right?
Absolutely. I think it's really difficult for GPs. They've got 10, 12 minutes with a patient to try and elicit all those symptoms. And it's very difficult for patients as well. They don't present like a textbook. So I think in those cases where you're not sure, asking them to keep a mood diary for a few months, 3 to 6 months is perfect. It allows us to then visually have a look at what the symptoms are, when they're happening, what the duration is, to have a bit more evidence behind that referral.
Yeah, certainly our mental health practitioners in PCMH, that's what we would do with the patient, is try and understand the context of their mood, and help them with building the skills, like you say. So wonderful. So what other help is there out there to guide clinicians? I mean, obviously this podcast is incredibly useful, but what else is out there, Pranav?
So there's national resources. So obviously the NICE guidelines set out in a really clear way how to manage someone with bipolar, and not just in terms of secondary care management, but also that sort of monitoring that people will need who have an SMI. The Bipolar UK website is a great website to refer patients to, but it's also a great website that I use quite a lot to sort of explain certain symptoms, to look at other resources that people might find useful. And then there's also things like the STEP bipolar course locally, so the short-term education program, which is a great course for helping people to understand their illness, to recognize some of those early signs, and to understand what the treatments are about.
I think we've also got locally some Bipolar UK peer support groups as well. I think one of them is run by one of our connectors. So again, really great that we've got all these different ways to help patients feel in control of their symptoms and understand a bit what's going on for them. Awesome. Well, that for me has really helped me understand bipolar as well. So Thank you so much. I'm going to leave it there unless there's anything else that you'd like to add, Pranav.
No, thank you so much for your time.
Well, you're going to be the host next time, aren't you? So the next podcast is going to be around the nutrition, metabolic system, and cardiovascular health. So I look forward to hearing that. And thank you to everybody who's tuned in for this first podcast. I hope you found it useful, and see you on the next one. Thank you.